Their eyes can also bother them at those times. And these are the patients that have tree pollen allergy, grass allergy, weed allergy. And there are characteristic features. Tree pollens are out in the spring, at least in this region. Grasses in the late spring and summer, and weeds are out in the fall time. Perennial allergic rhinitis is characterized by prominent chronic congestion. They have less rhinorrhea and pruritus, although they do, but the congestion is really prominent, and it's due to things like dust mite allergy, cat or dog allergy, mold allergy, things that you're exposed to commonly. And again, you have this chronic exposure, you generate edema, and you develop congestion. So how do you diagnose it? Well, you look at what they're exposed to. You look at seasonal variation. You also look at daytime variation. You know, the kids that wake up in the morning with bad symptoms start thinking about dust mites more than anything. You look at family history. These things run in families. And you look at personal atopic histories. This is a child who had severe eczema when they were young. Again, that goes along with the diagnosis. You do a thorough nasal exam looking for edema of the inferior turbinates, pallor of the turbinates. You're looking for discharge. You can do therapeutic trials, so you can put them on the right medications, on non-sedating antihistamines or nasal steroids, and see if they improve. In some children, you want to identify what they're allergic to, so you can do skin testing, you can do in vitro RAS testing, which I'll go over a little bit. And you can do nasal smears looking for eosinophils, which we don't do commonly, and only in those cases that are particularly problematic diagnostically. So if you want to diagnose allergy, I mean, we do skin testing. So you take the allergens and you scratch the surface of the skin, put the drop on, see if they make a hive. It's sensitive, it's cost effective in the allergist's office. It's not cost effective if you're referring in though. It gives you a quick result, and it has a very good negative predictive value. RAS testing can be done. It's much more expensive. The accuracy is pretty much equal to skin testing. A limited RAS testing panel may be helpful. Keep in mind, a lot of the labs will advertise these panels that have 50 different things, and they're incredibly expensive and not particularly useful. So when you do these, you want to test for what you're interested in testing for, and not testing for a ridiculous number of things. Also, in these patients where you're worried about allergic rhinitis, nasal, upper respiratory tract symptoms, you don't test for foods, and a lot of the RAS panels have foods tacked on, and they're problematic, which I'll get into. So when they're used judiciously, they can be beneficial. How do you treat these patients? And first and foremost, why do they have symptoms? Those with allergic rhinitis, they're exposed to things they're allergic to. It triggers their immune system. So if you can cut down on exposure to the things they're allergic to, that's what you want to do as first-line therapy. So dust mite covers, washing the sheets in hot water for dust mites. Mold, you want to decrease humidity, clean down visible mold. Things like pollens are much more problematic, but for kids who are bad, you want to keep the windows closed, run air conditioning, have them change clothes when they come in. In terms of medications, the first-line therapy for most of these patients is going to be non-sedating antihistamines. So there's 3 generations of antihistamines. The second generation are the ones that you're most common to using. Cetirizine, loratadine, fexofenadine are sort of the generics. They last for anywhere from 12 to 24 hours. They don't cause sedation. They're compatible with school-age children, so things like Benadryl and Atarax may be effective. You have to give them frequently, and school performance frequently is impaired. So non-sedating antihistamines, first-line therapy. Problem with non-sedating antihistamines is they do absolutely nothing for nasal congestion. So the patients with rhinorrhea, itching, sneezing, eye allergy symptoms, antihistamines, nasal congestion is more problematic than intranasal corticosteroids are really the most effective medication we have for all symptoms, including the ocular allergy symptoms. Other medications that are available, decongestants, which really have a limited role, things like pseudoephedrine, you certainly don't want to use them long term. Leukotriene antagonists like montelukast, and the problem here is they've been marketed very heavily, and the data on effectiveness really is very marginal. So it's in the armamentarium. They're being used much more frequently, but really in terms of effectiveness, they're not all that beneficial for most patients. There are a subset that respond very well. Intranasal cromolyn you can use, not the most effective medication we have. And you can use anticholinergics like intranasal ipratropium bromide, which is particularly useful for patients with vasomotor rhinitis. So you go out skiing, your nose runs. Ipratropium bromide is great and works very effectively. But for the vast majority of your patients, it's going to come down to an intranasal corticosteroid or a non-sedating second-generation antihistamine. You can also use eye drops for the ocular symptoms. And you base it on the patient. I mean, you look at the patient's symptom complex and at their age, and you base your treatment regimen based on that. So question 3, immunotherapy is effective for all of the following except seasonal allergic rhinitis, perennial allergic rhinitis, stinging insect allergy, food allergy, allergic asthma. So so D is the answer. So it's effective for allergic